Hi everyone, my name is Kishni Lovina Tyagarajan. I'm from Kuala Lumpur Metropolitan University. Here I want to present my case study for neuro. Demography data. My case study's name is A. His chronological age is 2 years old, 7 months and 2 days. On the date that I have start my assessment. The date of birth is 9 June 2014. Gender male. Religion Islam. Race Malay. He's staying at KL also. Dominant hand is right hand. The date of referral is 11 January 2017 and the purpose of referral is ADL training and the diagnosis is cerebral palsy. Okay, what is cerebral palsy? Cerebral palsy is a general term for a number of neurological conditions that affect movement and coordination. Neurological conditions are caused by a problem in the brain and the nervous system. Specifically, cerebral palsy is caused by a problem in the part of the brain responsible for controlling muscle. The conditions can occur if the brain develops abnormal or is damaged before, during, or shortly after birth. The sign and symptom of cerebral palsy. The symptom of cerebral palsy is normally become apart during the first 3 years of the child life. A child with cerebral palsy may be slower in the achieve important developmental goals such as learning to the crawl, walking, and the talk. The main symptom is largest depend on the specific form of cerebral palsy the person has. The four main type of cerebral palsy are the spastic cerebral palsy, the kinesthetic cerebral palsy, and ataxic cerebral palsy, and mixed cerebral palsy. The symptom of cerebral palsy differ in severity from person to person. Some people only have a mild problem, while others have severely disabled. The area affected by the cerebral palsy can also vary. Some cases only affect one side of the body, some affect primarily the legs, and some affect both the arm and the legs. Spastic cerebral palsy, when the muscles are weak and stiff, there is a hypotonic, especially if moving them rapidly. Kinetic cerebral palsy, where the muscle tone, unconscious ability to contract or relax and muscles, verified between stiffness and hypotonic because random and uncontrolled body movement, involuntary smiles and postures. Anticic cerebral palsy, where a person has balance and coordination problem, resulting movement, they may also experience tremor in their hand. Causes of cerebral palsy. Cerebral palsy is caused by a problem in the part of the brain responsibility for the controlling the movement. It can occur if the brain is damaged in early life or developmental abnormal. Although the exact cause is not always obvious, part of the brain responsible for other important functions may also be affected such as communication, hearing, vision, the ability to learn. This is why the person with cerebral palsy can have various other problems which don't involve the muscles. What are the causes? The problem in the brain. In the past, doctors believed the cerebral palsy was usually caused by the brain damage uncertain during birth, the direct result of being temporarily deprived of oxygen. The hesitations can sometimes that occur during a difficulty or complicated birth. However, a major research project carried out in the 1980s shows that in the baby born at term was responsible for less than 10 of the cerebral palsy causes. Most were due to problems with the brain that developed before the child was born. The research believes there are three main problems that can affect the brain before the birth and the causes cerebral palsy. Personal history of A. Patient name is A and he is 2 years old. Good in socialization, responds positively to the familiar adult. He easily can attach with everyone. He also a seeker attention and fear of the height. He also good expressions, happiness and affections. Watch person in direct line of a visions only for limit time only. And he spent his half of day in the center because his parents sent to the to the center early in the morning and fetch him in the evening after they came back from the work. Family history of A. A have two sisters, one mother and one father. And A is the youngest brother and elder sister and another sister for him. Social economic status. According to the patient parents, the financials of the family is normal and no problem about supporting their child. Medical history. Patient does not take any medication presently. Patient is good in general health. Patient recently wearing glasses because long distance sightness. Social, social history. Pre-morbid. A don't like to make friends with others. No eye contact. Post-morbid. A likes to make friends with peers in the therapy centers and try to improve his eye contact right now. Education. Recently, A taking special education classes at the school that's situated in a therapy center, and also he going good improvement and showing some interest in his studies. Evaluation. Subjective assessment. A need more strengthening activities because he has a very weak hand muscle so that it affects his activities of daily living. A will follow his parents and therapist instructions. He take more time to eat because he not chew or swallow the food. He just keep his food inside the mouth. He just take a longer time to finish. And also he in good in question and answering. And also lastly is A very fear of the height. Objective assessment. Occupation performance areas. The first one. In objective performance areas, the area that I assess is ADL and IIDL activities of daily living and instrumental of activities of daily living. And the assessment that I use to assess the ADL and IIDL is school function assessment. Okay, for school function assessment, school function assessment for the ADL, these are the assessment that I have gone through with A. You can have a look on these slides. Summary of school function assessment. A can't perform well his activities of daily living and instrumental of daily living without prompts because he have a weak muscle. The second part of evaluation is occupation performance components. There are four areas: sensory, fine motor and gross motor, cognitive and social psychosocials. For the sensory area, I use sensory profile assessment to assess the sensory. The second area, the fine and gross motor, the assessment that I use to assess is Peabody developmental motor skills and cognitive. The assessment that I use is school function assessment, and the psychosocial, the last one, assessment that I use is school function assessment also. Sensory component, sensory profile assessment. The first one, A, auditory processing. A can't work with the background with the noise. He will easily distract from the noise because he cover his He has to avoid noise, and also he will react depressed with sometimes. B. The visual processings. A is okay with the bright light and dark light. He is like easy go with the dark and the bright light. He won't react any reactions for the bright and dark. It's just good with any environment. C. The vestibular processings. A seek all kind of movement and this interfere with the daily routine, but he can't walk. He likes to rocks and punching on the balls, but he fear of the falling and the height so that he move less. The D is tactile processings. He express distress during the grooming, washing hand, combing the hair, brushing the teeth. He don't like some personal works, but whenever he close to anyone, any adult, by touching it's okay for him. But certain grooming things is he avoid. He distracts with the grooming activities. The oral sensory processings. A can't eat all kind of food, but he take longer time to eat because he won't chew and swallow the food. Just keep inside the mouth only. It's only problem for him for oral. F. The proprioception processing. A hold onto the wall and the banister to walks and fear of the height and the falling from the height. G. The olfactory processing. Most of the time he smells his things before use and eat before eat. The summary of the sensory processings: olfactor seeker behavior, tactile seeker behavior, proprioception seeker behavior, oral avoider behavior, auditory seeker behavior, vestibular seeker behavior, and visual seeker behavior. The second area, fine and gross motor. Assessment that uses P-body developmental motor skills assessment. P-body developmental motor skills has 6 subsets to assess the client motor skills, but I use 4 subsets to measure my clients. The subsets that I use is the stationary, locomotion, object manipulation, and grasping. Okay, the first part of the P-body developmental. First one is stationary. This subset measure a child ability to substance the control of his or her body within its center of gravity and return the equilibrium. A's raw score for the stationary is 37 and his age of the stationary is 14 months. The second part is the locomotion. This subset measure a child ability to move from one place to another. The actions measure including crawling, walking, running, hopping, and jumping forward. A raw score for the locomotion is 68 and his age of the locomotion is 12 months. The third one, object manipulation. This subset measure a child ability to manipulate the balls. Example of the actions measure including catching, throwing, and kicking because these skills are not apparent until a child has reached the age of 11 months. This subset is only given to children aged 12 months and older. A raw score for the object manipulation is 4 and his age of object manipulation is 12 months. The fourth is the grasping. This subset measures a child's ability to use his or her hands. It's speaking with the ability to hold an object with one hand and the progression up to the action involving the controlled use of the fingers and both hands. A's raw score for the grasping is 40 and his age of the grasping is 14 months. The summary of the cognitive functionings: A need prompts to remind his perform his work, where to place his thing, what to do next, and etc. If not, he will just mingle around in the center without doing anything, or will just keep quiet and silent himself and stay at one place. The fourth area that evaluate is the psychosocial, the assessment that uses school function assessment. You can have a look on the assessment that I assess on the screen. The summary of the psychosocials. A recently he could try to make friends with certain kids in the center, but he don't how the way to make a friends. A don't like to listen for the therapist if they are not strict with him, and also the therapist have to force him to do work. He can't not cooperate with the therapist as well, everything based on his emotions. Problem identification. For the part one is occupation performance area, the area part. He is unable to dress his shirts. That is the one of the problem for in Ariel. The basic things is still he can't do it. And the second part, the occupation performance components in evaluation part. The first area, the sensory, poor in balance. And the second part, fine and gross motor, abnormal pencil grip, cognitive, unable to identify the body parts. For the psychosocial, avoid to communicate, rare in talking with others. He's like whenever adult go and talk with him, then only he will talk. If not, he will just keep quiet. He won't talk, just silent. It's very rare to talk or communicate with others. Intervention. The treatment plan and the goals for the activities of daily living based on the problems. A will be the short-term goals. A will be able to take off his shirt with minimal gastroprom in 1 month, and the long-term goals is A will be able to put on his shirt independently with minimal verbal prom in 3 months. The treatment plan and goals for the sensory. The short-term goals is A will be able to balance himself in normal gravity is the floor with minimal support in 1 month, and the long-term goals is A will be able to balance himself in normal gravity floor with independently in 3 months. Treatment plan and the goals for the fine and gross motor. The short-term goals is A will be able to form a proper pencil grip independently in 1 month, and the long-term goal is A will be able to draw a circle, horizontal line and vertical line with independently in 3 months. The treatment plan and the goal for the cognitive. The short-term goal is A will be able to identify the body parts with minimal gastroprompts in 1 month, and the long-term goal is A will be able to identify the body part with independently in 3 months. The treatment plan and goal for the psychosocials. The short-term goal is A will be able to use yes and no appropriately, say yes or no to the meal time, breakfast, lunch, and dinner with minimal verbal prompts in 1 month. And the long-term goal is A will be able to use yes and no appropriately, say yes or no to the meal time like breakfast, lunch, and dinner independently without any prompts in 3 months. Patient assets. A's parents are very support for A. A parents are willing to take him daily to the center even they're busy or he tired or not feeling well. Model of practice. Person, environment and occupation (PEO) model. Through this model, it has been indicated that occupation performance results from the dynamic relationship between people. The occupation, the roles and the environment is which they live, work and play. In the client-centered approach, but equally emphasized is a place on the environment and the occupation where design intervention (PEO) defines as person, a dynamic and changing with the skill and ability to roll over the time, and the environment, including the physical, social, culture, and institutional factors that influence the occupation performance. And the third, occupation means including self-care and productivity and leisures. The frame of reference, cognitive frame of reference, assessing the level of cognitive functions and providing tasks appropriately to the level, aim to describe the cognitive limitation caused by the chronic illness, identifying the remaining functioning abilities so that expectations of the client are realistic. Sensory integration frame of reference, the purpose to provide the evaluation and the intervention designed to identify, prevent, and remediate defects related to the child's sensory perceptual skills, process and praxis skills, sensory sensory sensitivities, and related pattern of functioning performance. These methods are used to achieve the overarching goals of occupation therapy to improve the client's health and participation through the engagement in everyday activities of occupations. Rehabilitation frame of reference. The independent is achieving through the adaptation device orthopedics, environmental modifications, wheelchair modification, ambulator aids, adaptive procedures, and the safety educations. The focus of this frame of reference is to able the greatness among the independence for the person in safely and its timely manner complicating their ADLs, engaging in meaningful leisure com- occupations, having a needed skills. Developmental frame of reference. The developmental frame of reference is based on the theory of human developmental in and across all skill areas. For example, the physical, cognitive, psychosocial, psychological, and emotion. The aim of the developmental frame of reference is to identify the highest level motor, social, cognitive skill in which a client can engage and facilitate improve in the function from the one starting point and grade the activity so that the client can achieve them but is slightly change help to close the gap in the area in which the client is unable to perform. Humanistic frame of reference. In it consider apart the individual view of life, but it take more holistic perspective. In this frame of reference can change occur through the relationship with other and it's seen as virtual of compliance with the treatment and unlimited of the successful rehabilitations. Biomechanical frame of reference is the key reference to use is this conjunction with various other is enabling the OT to assess and identify a client occupation performance with various activities of daily living. Biomechanicals looks into a client physical capacity such as movement, muscle, strength and endurance. Treatment implementation. The problem once the treatment implementation unable to dress and undress the shirt. The treatment that given is the training in ADL dressing and terminal behavior is child will able to dressing him and herself independently. The frame of reference that I use is rehabilitation frame of reference and biomechanical frame of reference. The condition and the method is I use is the backward chaining. The therapist assists the child to lay out the shirt and pull over the head, place each arm into the armhole. Pull the sleeves over each arm and give the prompts get dressed. Child will pull the shirt down to the vest. These are the steps that I'm going through. And the therapist assists the child to lay out the shirt and pull the shirt over the head and place each arm into the armholes and give the prompts get dressed. Child will pull the sleeves over each arm and pull the shirt down to the waist. The therapist assists the child to lay out the shirt and pull the shirt over the head and give the prompts get dressed. Child will be placed each arm into armhole and pull the sleeves each arm and pull the shirt down to the waist. Therapist will assist the child to lay out the shirt and give the prompts get dressed. Child will pull the shirt over the head and place each arm into the armhole and pull the sleeves over each arm and pull the shirt down to the vest. And when the given the prompts get dressed, the child will be lay out the shirt, pull the shirt over the head and place each arm into the armhole and pull the sleeve over each arm and pull the shirt down to the vest and generalize to the various material therapies will setting and the prompts and the criteria is for the beginning or non-timing section is after the section or can set time to finish pre-section for 15 minutes and the rest is if the child is able to dress or undress himself, it can lessen his mother's burden because his dressing is still a basic living activities. Some more and is can he a mother can focus to other important things and child can also learn from basic things to complete works and he can develop his performance from basic and the precaution is environment should be free from the casual distractions. Problem number two, poor imbalance. The treatment that I use is the sensory integration therapy, and the terminal behavior increase the balance. And the frame of reference that used it for this problem is the sensory integration frame of reference. The condition and the method that used for this problem is the activity to improve the balance, like walking over the bolster length of the very height and stair walking and slide up and down walking on the bench for the balance and the coordination, walking on the beanbag, jumping on the trampoline, and hopping one foot by tapping one leg. Recreation for the 10 minutes. And the rationale is the balancing can improve him or her ADL and IADL because balance is our self is important to do other works. And the precaution is environment should be secure and free from the casual distractions. Treatment plan. Problem number three, abnormal pencil grip. The treatment that I use is position to prepare for a gripping the pencil and writing. The terminal behavior is able to perform a proper pencil grip. The frame of reference that I use for this problem is the biomechanical frame of reference, developmental frame of reference, and rehabilitation frame of reference. The condition and method that I use for this problem is improve the muscle tone, improve the small muscle of the hands, working in the vertical positions help strengthening the whole arm which is an important foundation skill for writing and heavy working activity to develop a arm muscle, push-ups, crab walk, swimming in the trapeze and recreation is for 30 minutes. Freshness if the pencil grip is can be used to help the child to achieve a mature, effective, correctly pencil grasp, and it's important for the child to develop a mature, effective, and correct pencil grasp is by going through the developmental appropriate stage of various pencil grasps. And the precaution is environmental should be secure and free from the casual distractions. Problem number four, unable to identify the body parts. And the treatment they use is acknowledge the child about the simple step with modeling pointing to the body parts. Terminal behavior is able to identify the body parts. Basic parts is like eyes, nose, mouth, ears, head, hand, legs is the basic parts. And the frame of reference is the that I use for this problem is the developmental frame of reference and the cognitive frame of reference. And the condition and the method is for this problem is create a simple activity to develop a basic understanding steps for the body parts and guide all the activities that do every day and by pointing the body parts and giving reward when they are complete the steps even not good enough and encourage to do works that he can learn more, such as like coloring, drawing of songs regarding about the body parts. And the criteria is do any time and all the time. And the rationale is by applying the basic step understanding, he can perform his work independently so that he can learn new and more about the study and understanding the basic step is very meaningful because he can perform any other outdoor activities. And the precaution is ensure the child understand the way of doing and assist and supervise the child always and ensure the instruction that given is simple and clear to understand by the A. Problem number 5, avoid to communicate. The treatment that uses social training throughout the interaction and play with the siblings or friends, a child will develop a social skill and interpersonal skills alongside their communication skills. The terminal behavior is the child will communicate the basic device and the needs. The frame of reference that used for this problem is humanetic frame of reference, developmental frame of reference, and rehabilitation frame of reference. And the condition, the method for this problem is where represented with adhesive items given by the prompts what to wear, and child will be response with correct words, sign or pictures, and repeat one step with what no prompts. When the present give a need situation, give the prompts. What do you need? Child will respond with correct word or sign of picture. Repeat the step 3 with no prompt and generalize to various material therapies, setting the prompts, and the duration is 20 minutes. These are the steps to how to work on in communications and rational. The ability to communicate effectively is a key skill. The better we are it, the better our quality of the life will be. We will begin a communication for a moment we are born, letting our mother know we have arrived with our first cry as a child develop. It is important we nurture the communication skills so they are capable to express themselves early and confident in all aspect area of their life. And precaution is ensure the eye contact and ensure the instruction and clear and simple. Home programs encourage the patient to do practice writing and educate the caregiver about the dressing steps to teach their child and encourage the patients and the parents to do activity like wheelbarrow walk and push up to strengthening their hands and educated the caregiver about some method to calm the child when they get too active during some home programs. The future plan is to continue the treatment as above and to reassess the patient if possible and to visit the Sham Physio Center again. The prognosis is the rehabilitation. A won't miss the appointment to come occupation therapy. His mother will be able to follow the instruction given to her about the treatment session. And the medical A also be newly start to try to stand by himself. The reference, and thank you for listening my case presentation. Thank you.